It's really like a pleasure for me to be here and moderate this event where we're gonna, take a closer look at your placenta. So it's, it's a privilege, it's an honor to moderate this event. I really feel that I have like a strong connection with the speakers and maybe somebody in the audience. As 11 years ago, my wife and I experienced preeclampsia with our first daughter. And as you can imagine, she was born at 29 weeks, 2 pounds, 8 ounces, and she spent almost like 4 months in the NICU. So as you can imagine, it was like a very difficult time as a parent, first-time parent, but it was also like a very hard time as a scientist, as I am, because I recognized that medicine really had very little that could do to predict, prevent, or manage, some like that type of like a prenatal complication. So that's why I'm very excited to be here today. We have here as two speakers, Dr. Parast and Dr. Karen Mestan. And they are two stem cells experts, and they are basically bringing us today some of their studies where they're modeling, or the way they're modeling human placenta development, and also how they are evaluating placentas after delivery. So that hopefully is gonna bring us sort of like into the next steps towards personalized medicine and personalized care. So it's my pleasure to introduce actually Dr. Parast today. So she is the co-director of the Center for Perinatal Discovery, but she's also the director of perinatal pathologies at UCSD. She is a scientist, she's a physician, she's also a friend. I used to work with her in her lab a few years ago at this point. And she has a very well-established lab here at Sanford Consortium where she is studying the development of placenta across gestation. And she's pioneering some of the studies to use human pluripotent stem cells for modeling placenta in vitro. So please, it's a great honor to have here our first speaker, Dr. Parast. Please take it away.
Thank you so much, Matteo. And it's such a pleasure to be here today and to have the opportunity to share with you our research on the placenta. So I'm going to talk to you today about the human placenta, and it's one of the most underappreciated organs. And back in 2014, when the National Institute for Child Health and Human Development launched the Human Placenta Project, they declared that this organ was one of the most poorly understood organ in humans, and they were right. Hopefully by the end of this talk, I'll also be able to share with you and that you can appreciate that the placenta is also hugely underestimated. So some very sort of broad facts about the placenta that is sometimes misunderstood. So a lot of times people think that the placenta is a maternal organ. It, in fact, is a fetal derived organ. It has the same genetic material as the baby. It is sometimes referred to as the diary of intrauterine life because it bears on it marks of the occurrences during life in utero, all the events during pregnancy. And also a lot of times it's thought of as being primarily a barrier, so a lot of people think of it as a barrier between, for example, pathogens that might infect mom during pregnancy, so a barrier between mom and baby. However, it's much more than that. So I hope to touch on that a little bit today as well. So with that in mind, I am going to, my portion of the talk, I'll focus a little bit on placental development. And then I'll talk to you about pathologic evaluation of the placenta after delivery, which is what I do as a clinician. And then finally, I'll end about how we, in our lab, we use stem cells to model this organ in vitro. So to begin with placental development, so you can see here in utero, the baby attached by the umbilical cord to the placenta, which is attached to the maternal uterus. And where this fully developed organ actually comes from early in development is from these outer cells of the human embryo. This is on the left-hand side, you're seeing the human blastocyst, so a very early stage, around 5 days after fertilization stage of human development. So what you're seeing here on the inside is a group of cells that are referred to as the inner cell mass. And these cells give rise to the baby, while these outer cells of the blastocyst that are called trophectoderm, or TE for short, these cells give rise to the placenta. So very early on, these trophectoderm cells differentiate. And what that means is that they undergo a process to form cells with specialized functions. And they form these cells that are generally referred to as trophoblasts. So these are the specialized placental cells. Their name comes from the Latin root tropho, which means to feed, understandably so, because that's one of the functions of the placenta. So now when you start with the trophectoderm, the first thing that happens is that these cells expand and give rise to what are called trophoblast stem cells. So these are the stem cell precursor of the placenta. And then as these cells grow, they further differentiate. This is, again, very early in placental development. They give rise to two main cell types. One of them is called the extravillous trophoblast, and the other is the syncytiotrophoblast. So as you can kind of see, this is a cartoon representation of these cells, but basically as the stem cell develops into the extravillous trophoblast, they develop into these elongated cells that are very much like cancer cells. They're very invasive, and they invade the maternal uterus, and they help anchor the placenta to the maternal uterus. Whereas on the right-hand side, you're seeing the syncytiotrophoblast, which comes from these stem cells fusing together to form these multinucleated cells, which have different functions. So the stem cells actually just self-renew and make more of themselves, while the extravillous trophoblast help, as I mentioned, anchor the placenta to the uterus, and they directly crosstalk with maternal immune cells. So they help promote immune tolerance. This is how the placenta, which is in fact half dad, half mom, is tolerated by the mom's immune system. They also help regulate, these maternal immune cells help regulate the level of invasion that these cells undergo in the maternal uterus. And it's a very interesting process that has been studied over many years. Then on the right-hand side, the syncytiotrophoblast, as I mentioned, arise by cell-cell fusion of the stem cells. And these cells are the primary cells that are involved in nutrient and gas exchange. They produce many different kinds of hormones. They also help evade the maternal immune system. They actually don't express normally any molecules that helps the maternal immune system recognize them. So they evade the maternal immune system in that fashion. They all are also a barrier against pathogens, but they're a lot more than that. They also help communicate with mom, and this communication is sort of long-distance communication, unlike the extravillous trophoblast that actually communicate directly with the maternal immune cells. The syncytiotrophoblast secrete factors and extracellular vesicles, which communicate remotely with all different types of maternal organs, including the maternal lung and other maternal systems. Now, it is the formation of these cells early on in pregnancy that when the formation of these cells or the function of these cells is affected early on in pregnancy, this is what gives rise to a lot of the different placenta-based pregnancy complications and neonatal complications that we're going to talk about today. So why do we look at the placenta after delivery? So again, as I mentioned, placenta is really thought of as a diary of intrauterine life because it bears the marks of various events that have occurred throughout pregnancy. So very sort of generally, the reasons that a placenta would get sent to our department for evaluation is because either mom had a complication, baby had a complication, or the placenta is abnormal in some way or shape. A lot of times what we do as placental pathologists is that we confirm or identify the etiology of the maternal or neonatal complication. But occasionally we also, through the placenta, by evaluating the placenta after delivery, we can actually see and provide evidence for a potential underlying maternal disease that has otherwise not been yet diagnosed. And I'll show an example of that. And then probably most importantly, we can, by evaluating the placenta, we can actually find what is the risk of recurrence of this complication, which can then inform the parent's decision and the parent-doctor conversation in terms of the next pregnancy. So one of the indications for placental examination is preterm birth. And preterm birth generally falls into two categories. There is spontaneous preterm birth, which can be associated with amniotic fluid infection, with a congenital infection such as CMV, chronic inflammation or what's called as velitis of unknown etiology in the placenta. Whereas an indicated preterm birth, that's when the delivery is induced because of a complication such as a maternal hypertensive disorder. As Matteo mentioned, preeclampsia is one of those. You can also, a woman can undergo induction and be delivered for diagnosis of intrauterine growth restriction, and also for maternal diabetes or macrosomia, or a large for gestation baby. So here's an example of a placenta that's showing inflammatory cells in the fetal membranes, and is also showing inflammatory cells coming out of these large fetal blood vessels that are on the fetal surface of the placenta. And this is evidence of chorioamnionitis with a fetal response. This is something that we see relatively often with spontaneous preterm birth, secondary to amniotic fluid infection. That's relatively common. Here's a more rare example of what we see during placental evaluation, and that is a placenta that is very stiff and also very pale. And you can see that on cross-section here, the placenta, which is normally this very red, spongy organ, has a lot of areas that are fibrotic and white. And what this is a lesion called massive perivillous fibrin deposition, or maternal floor infarction. This is a relatively rare condition that is associated with intrauterine growth restriction, but it's very important to diagnose because this can actually be the cause of recurrent IUGR in the setting of maternal autoimmune disease. So occasionally we see these cases where mom does not have this diagnosis just yet. And so by evaluating the placenta in the setting of IUGR, not only can we identify the underlying etiology for IUGR, but we can also pinpoint that she should probably be screened for autoimmune disease, as this condition can actually be prevented if she's diagnosed and treated in a subsequent pregnancy. And then finally, here's another example of a setting where we would evaluate the placenta. And you can see here an abnormal cord insertion. This is referred to as a membranous cord insertion or velamentous cord insertion. And here it's associated with a thrombus, a clot in the fetal circulation, and avascular villi. And when these findings are present in the setting of a stillborn baby, this can provide evidence for a cord accident. And this way the family can be told that the risk of recurrence of this lesion is low. So again, some examples of what we see on the perinatal pathology service and how they can serve as informing the parents and the doctor about the various complications. But really, I want to talk also about pathologic evaluation of the placenta, but beyond the immediate outcomes. So what we're learning more and more over the past 10 or so years is that by evaluating the placenta, we can identify maternal risk factors. So by identifying, for example, myometrial fibers at the maternal surface of the placenta, we can identify patients that are at increased risk of developing what's called a morbidly adherent placenta, or also referred to as placenta accreta spectrum. By identifying severe forms of decidual vasculopathy by looking at the few maternal vessels that are present in the fetal membranes, we can, by diagnosing this lesion, we can actually identify patients that are at increased risk of cardiovascular complications later in life. And then with respect to the baby, we are learning more and more over the last 10 or 20 years this idea that in utero life can actually program the baby for both health and disease later in life. So this is a hypothesis that is referred to as developmental origins of health and disease, or DOHAD. And this really means that during in utero life, the baby is getting programmed, the baby's organs are getting programmed for either health or disease, and these effects can extend to the lung, liver, brain, metabolism. So pediatric risk of obesity, for example, can be determined by in utero life. So placental evaluation can really serve as a determinant of life exposures and what is potentially to come if we can harness that information. And this is what we do here at the Center for Perinatal Discovery. Is our focus is on the human placenta as really a biomarker for both maternal complications and neonatal adverse outcomes and programming of disease. So what we have been doing here at the center over the past 10 or 12 years is we focused on following women during pregnancy. So our reproductive cohort has consisted of consenting patients early on in their pregnancy and following them, documenting any underlying diseases that mom has or any pregnancy complications that she develops, any exposures that she has during pregnancy. And then we've really focused on more immediate neonatal outcomes. And what we're hoping to do going forward, however, is to also be able to follow these babies, at least first during the 5 years of life and then later into adulthood, in order to better understand the programming of disease. And so our work is centered around this perinatal biorepository, which is rich with maternal samples and also placental and cord blood samples at delivery. And we've used these samples to identify biomarkers for prediction and diagnosis of pregnancy complications, to also probe the mechanisms of perinatal loss, and then hoping again to go into the direction of developmental origins of health and disease. But today, as kind of the last portion of my talk, I'd like to touch on how we are using stem cells to model the human placenta as one of the big efforts at our center. So really, one of the issues with having only the placenta at delivery to evaluate is that you're looking at an organ that basically has gone through its life, and so you're kind of doing a post-mortem on it. And so while it is important and you can learn a lot of information about what's happened, you're really not able to probe what happened to this organ early in its life. So what we're doing here at the center is we are banking umbilical cord cells, and through a process called reprogramming, by introducing 4 specific genes into these cells, we can reprogram these cells and form what are called induced pluripotent stem cells, or iPSCs. These iPSCs can then be converted to trophoblast stem cells, these placental precursors, and be used to model the early development of this particular placenta, no matter whether it was normal or diseased. And so we've actually used these iPS-derived trophoblasts, and our publications, our work have shown that these iPS-derived trophoblasts have very similar responses to placenta-derived trophoblasts, for example, to conditions like hypoxia. We have studied these cells that are affected by trisomy 21 and have shown that just like placenta that is affected by trisomy 21, the iPS cells that are affected by trisomy also have the same defect in formation of syncytiotrophoblasts. And most recently, we have, in fact, identified abnormalities in trophoblast differentiation and responses to oxygen tension that iPS cells from placentas affected by preeclampsia exhibit. And so this has been very exciting to show this proof of concept that, in fact, placenta-based pregnancy disorders can be modeled using iPS cells. Going forward, what we're also doing is we're banking maternal blood cells from the same pregnancies, and we hope to also reprogram these into iPS cells, and then subsequently differentiate them into maternal cells that are at the implantation site, including decidual cells and maternal immune cells, because then we can combine these and actually model events at the implantation site, which can give rise to disease later on in pregnancy. And this really could provide, for the first time, a way to model this kind of inaccessible site during an ongoing pregnancy. And in addition, we can again use these same cells, the placenta-derived iPS cells, because as I mentioned, these have the same genetic material as the baby. We can also use them to model fetal organs, such as the lung or the brain. And we're hopeful that in the near future, we can also put these two cell types, both the iPS-derived trophoblast and the iPS-derived fetal lung or brain cells, in order to be able to understand how the placenta, in fact, programs fetal cells for normal or for development of disease. And with that, I would like to thank my group here at the Sanford Consortium, and I would like to pass it on to Karen.
So thank you, Mana. That was like a very interesting talk with a lot of information. Our second speaker today is Dr. Karen Mestan. She's like the division chief of neonatology at UC San Diego and Rady's Children's Hospital. She has like a significant experience in clinical and research. And she actually recently joined us like a year ago after spending like 20 years at the Northwestern University. So her lab here is focused on identifying some biomarkers that could be useful in predicting, preventing, and managing some serious conditions that may affect high-risk infants. So it's a great pleasure to have Dr. Mestan here with us today, and the podium is yours.
Thank you. Thank you so much, Matteo and Mana. So as Matteo mentioned, I am a neonatologist. Neonatologists are specialized pediatricians who maybe notoriously have been known to have to be cool and calm in the delivery room. For all kinds of cases. What they are not good at doing is being on TV. So this is a little bit different for me, but thank you so much to the Stem Cell Program for organizing this program here today. So let me just start out with the basics, because a lot of you are probably wondering, what is a neonatologist and what do we do? Again, like I said, we're a subspecialty of pediatrics. I'm trying to bring a little bit of a bedside approach to this presentation and let you know how to bring to life this organ that Mana has talked to you about, the placenta, and how complex it is and what it means to the neonatologist. A lot of the research and attention that we put on the placenta is really based on the maternal side and maternal health, and what we've been able to do over the past 10 to 20 years through our research and through a lot of the initiatives that we have in clinical care is to try to bring the placenta as a diagnostic tool to help improve not only newborn care and management, but also long-term health of our pediatric patients. Neonatologist is a work in the NICU in a hospital-based setting, and our patients are those who require critical care and monitoring for illnesses and special needs. The most common being prematurity, that is babies born at less than 37 weeks, so before their due date. Birth weight, low birth weight, so infants weighing less than 2,500 grams, or those about 4.5 pounds is usually kind of an entrance criteria for requiring NICU monitoring. Intrauterine growth restriction, in which a baby's growth may be tracking below what they're expected to be growing in utero, and so at the time of birth, their birth weight is much lower than what their expected gestational age weight should be. We also treat conditions in which there are congenital malformations, birth defects, sepsis, and infections in the intrauterine and newborn period. Breathing difficulties such as respiratory distress and apnea, which is when a baby kind of forgets to breathe, and those are babies that require critical care and continuous monitoring for their blood pressure and vital signs. A lot of babies also present with concerns for seizures and other delayed transition due to their physiology. A little bit about the history of neonatology. I've been doing this for over 20 years, over 30 years, if you count all the training that it does take to become a neonatologist. And what we've seen over the years is many advances in NICU care that have led to significant decline in morbidity and mortality in our very tiniest patients. This has been achieved through a combination of technologic advances, enhanced understanding of newborn physiology, much of which has been through research, and improved obstetric and pediatric practices. This is a graph from the March of Dimes Foundation 2022, which shows a pretty stable preterm birth weight of about 10% in the US. So if you think about 3.6 million births in the US, that about 360,000 of those are preterm and require NICU monitoring. But even above that, about 10 to 15% of babies born each year, because of other diagnoses other than prematurity, are admitted to the NICU each year. And as I said, I'm the division chief of neonatology here. I started last year in October, and I oversee this amazing group of over 25, almost 30 neonatologists. And we actually cover 10 NICUs in the San Diego area, spanning all the way up to Murrieta and all the way down to Chula Vista. And as you can imagine, there are many more NICUs across the country, and many people wonder, like, how many babies are actually being born each year. And for a neonatologist that works in the NICU, there's, for any one neonatologist, it seems like almost a baby a minute. So there's a lot out there. Again, like I mentioned, there have been many advances in neonatal medicine, and that has been all through, or a lot of it through maternal-fetal research. If you go back to the 1990s, the big advance in neonatal and newborn care was the development of a medication called surfactant, which we could give to newborn babies who had premature lungs, which allowed them to survive. And over the years, 3 decades ago, even a baby born at 34, 35 weeks, their survival was tenuous. Now we are treating babies born at even lower than 25 weeks gestation who have very favorable outcomes in the new neonatal era. Again, many advances in medications, nitric oxide, different forms of mechanical ventilation. There have been strategies and innovations to improve and protect the brain, which we didn't have before, through therapeutic hypothermia, prenatal steroids, a human genome project, non-invasive perinatal testing. And even most recently, and very relevant to this group here, is that in the 2020s, just recently, there's been a very high interest in looking at stem cell therapies and regenerative therapies to treat and improve the neonatal outcomes in our high-risk patients. And that has kind of led me to studying the placenta, as Mana explained in her presentation, that many of the keys to understanding and also treating neonatal problems for our babies is in the placenta. And this is something that I've come to realize over my many years as a neonatologist, is that a lot of the things that we're treating actually we're at the crossroads of maternal and fetal health, and that if we are very careful and we are very dedicated to understanding what that pathophysiology is, that we can improve not only the neonatal care of our patients, but also support their long-term growth and development. So you can see here the placenta, highly complex, as Mana said, poorly understood, often discarded, and still is, unfortunately, in our newborn management of children. But if you think of all the clues that could actually be understood in terms of fetal brain development, even programming of the neonatal heart and lung diseases that may be precursors to inflammatory conditions such as chronic lung disease, asthma, pulmonary hypertension, which are my areas of focus in the placenta. And again, a lot of my research interest started in really not only treating the baby, but also treating the family and the mother even before delivery, and realizing that there are many things that women are exposed to during pregnancy that may be linked to early childhood outcomes. Things like maternal psychosocial stress and mental health, environmental toxins, diet and nutrition, and even physical activity. These are all things that the modern era of neonatal research is partnering with maternal-fetal medicine and obstetrics and perinatal pathology to understand these mechanisms and how they may actually tie to complications such as preeclampsia, intrauterine infection, and chronic diseases such as diabetes, asthma, and obesity. And so this is just an overview of my very complex research, which could not be possible without the many lab members and many of my collaborators in this area of neonatal research at the maternal-fetal interface. And so in general, what I've been doing over the past 10 to 15 years, and now hope to continue full speed ahead with the Center of Perinatal Discovery and with the support of the stem cell program, is to take the placentas of the babies that we treat, whether they're premature or whether they're full term and healthy, to study not only the histology, but also collect these very precious progenitor and stem cells from cord blood and look at the milieu of the stem cells by looking at the plasma in which these stem cells arise, separating these cells, doing some pretty intricate and very state-of-the-art gene mapping studies, RNA-seq, single-cell RNA-seq, and a lot of the big data omics approaches that we have available here at UC San Diego. And we're also able to go to the bench and take these cells and the information from our patients and put them, incorporate them into humanized mouse models and mimic diseases such as bronchopulmonary dysplasia or chronic lung disease through exposure to hyperoxia and other things that we give to our premature babies during their NICU stay. And the whole thought of this and the whole mission behind this is, again, the development of novel drugs, technologies, and interventions for our NICU patients. These are just a couple of the recent publications that we've been able to disseminate in the past couple years. The most recent one is from JCI Insight. This is work that was done in Chicago, but is now being extended here at UC San Diego, where we're taking our monocyte progenitor cells from cord blood, and we're looking at the gene expression, and what we're finding is that depending on the placental pathology and the placental dysfunction from which these specific monocytes come, that you can actually see differences in how these monocytes express genes and also how they function in animal models. And this really highlights the importance of looking at our stem cells and saying, are these actually cells that can be programmed in the fetal and developing intrauterine period, where the placenta actually may be responsible for programming not only the monocyte progenitors, but also stem cells. And so this was another paper that another study that we conducted in which we looked at families contributed their cord blood, over 200 families in Chicago, and we did quite an extensive studies of looking at the concentration and composition of their stem cell components, and found that that they are different according to the placental histology. And work also that we're doing with twins, and the reason why I bring up this paper is that our family that has graciously come today are one of my patients in the NICU, a family of twins. And so we do quite a bit of work in this area, in which even when you think about the intrauterine environment of twins being the same, but their placentas may be different. And so what we've also been able to study is looking at the discordance in placentas from twin A and twin B, and seeing that that actually may impact lung and health outcomes in our newborn patients. And beyond the research, that's just a short overview of what we do. There's so much more. But the real question that that I have wanted to bring forth to you is this question of, is there a role for the placenta in NICU management? Because believe it or not, with all this compelling evidence, the placenta is really not used at the bedside in NICU management. And this is one of the missions that we really want to push forward, that is there a role that actually, if we, and I underline management here because placental pathology has been used to look at neonatal outcomes, like what are your outcomes, but can it be used to actually tailor how we treat our babies? And that's something that's a very novel area and a novel role for the placenta. But wouldn't it be wonderful if we had this information that our pathologists provide? We can look at inflammatory and vascular changes along the different domains of placental histology, which I've shown you here, and actually be able to tailor it a little bit more to a baby who may require steroids, a preterm baby who may require steroids, a baby who may benefit from antibiotics or tailored antibiotics, or even closer monitoring for late onset inflammatory conditions such as weight gain and nutrition, diabetes, immune disorders. And whether in placentas in which births arise from vascular dysfunction, if those are the patients that we need to be thinking more about stem cell-based cell therapies, growth factors, antioxidants, and closer monitoring for other conditions such as hypertension and cardiovascular disease. And then also the flip side of this is the power of a normal placenta. Can a normal placenta actually be valuable in reducing monitoring and saying that even though babies may be showing soft signs of some perturbations or disruptions in their delivery experience, but maybe they're more resilient because of the placenta, that may lead to faster screening, decreased NICU stay, and facilitate discharge, and overall our most important mission to really improve and support the family experience in the NICU and support our babies through early infancy and pediatric life. These are some of the upcoming studies that we have planned here at UCSD and through my lab, and also through the stem cell program, is to leverage a lot of these omics, genomics, epigenomics, transcriptomics, some of the newer technology that we have in metabolomics to actually define pathways of exposure that may be there during pregnancy that we can't see right now unless we look a little bit deeper. So those are the exciting things that I wanted to share with you, and I wanted to give a great appreciation and thank you for your attention. This is my lab. Again, I am very, very grateful to all the work that these young people do, many of them in the stages of their training that have been inspired by the work that we do at the bedside in neonatology. I actually have a website now that these young people have designed for me, so go visit www.mestanlab.com. And the most important thing that drives us as neonatologists, as researchers, as bedside clinicians are the families that we take care of. And a very, very happy story that I wanted to share with you is that even in my first couple months here as division chief, I had the pleasure of taking care of these little two twins, Colin and Patrick Higgins. And within a couple months after their discharge, the family, Mr. and Mrs. Higgins, who are here today, reached out to us, and we're very thankful for their experience in the NICU. These are the kind of families, and there are many of them out there, that really inspire us to make our job better and support our families, not only the babies that we treat, but the families that they go home to. And so really thankful again for this wonderful environment and this wonderful community of parents, families, researchers, and everyone. So thank you again, and I'll hand it back to you. And Mana wanted me to put our website for the Center for Perinatal Discovery down there too. So thank you.
Thank you, Karen. It was like very inspiring as well. As I mentioned in the agenda, we have also like the Higgins family here speaking with us. And please take the lead.
Thank you, Matteo.
And please, happy to hear your story.
Thank you so much. My name is Greg Higgins, and this is my superhero wife, Catherine Higgins. And you guys saw the picture of our two boys, Colin and Patrick, there. And our experience at the NICU was, I guess, spoiler alert, phenomenal. However, it didn't start phenomenal. It started very scary. And it started with, Colin was born, and he promptly peed on everybody. And that was exciting and great. But then when Patrick was born, he wasn't breathing normally. And so immediately what they did is they separated them. Patrick went to the NICU, or on his way down to the NICU, where they gave him some breathing apparatuses. And then, Patrick did that. And then Colin stayed up with his mom and stayed in the nursery or in that area. So I followed Patrick, and Catherine stayed with Colin. Shortly thereafter, Patrick exhibited some signs of a seizure. And this is where I learned the term of signaling, which I had no idea what it was until that moment, and I was there for it. And it was extremely scary because there was the word seizure was brought into play there. So at that point, there was a slew of testing that needed to be underdone and undertaken on Patrick to find out what caused the signaling, what caused him to do that, and how we can resolve that at the moment. I don't want to blather too long. He underwent tests, a lot of tests, and he's attached to every sort of electrode and diode that we could possibly get onto his little head. In the meantime, Colin is with his mother. Colin exhibited the same sort of reaction. While up in the nursery with his mom, and where he started to hold his breath. And so at that point, both of them were in the NICU, scaring us both, but giving us a little bit of sleep, which was helpful. And I guess, Catherine, I'll let you jump in. I don't want to blather too much. I tend to yammer, so I apologize. But if you want to jump in.
No, yeah, I mean, we're just here to say thank you. I mean, what you guys are doing from your studies to, the placenta matters, right? So, as a patient, what the NICU does is just, so much. We're new parents. Our families are not here. We're from the Midwest, and all hands on deck. And it was great that we were a part of that care, a part of the decision-making process. It was obviously frightening. We didn't deal with preeclampsia, but it was such a frightening experience. And it's the calmness and the care we received from the nurses to, the MAs, everybody that was there. They were, rocking the babies, and just, there was volunteers there that were making signs for Patrick and for Colin, and all of that just matters. And so what you guys do matters. And, anything we can do to field questions and anything we can do as parents of these NICU parents, it's just, you guys are angels in our book. So just a thank you. And, it's just so cool to see all the different studies and what that means to, the patient and our kiddos as they grow. So it's really interesting what you guys are doing, and we're happy to be here. So thank you. Is what we're here for.
Yeah. And we can't thank you guys enough. You guys are so professional. And Catherine says that, you allowed us to make decisions too. I solve problems for a living. It's what I do, and I'm passionate about it. I'm an engineer, and I run an engineering department, and that's what I do. And this is the first time presented with a problem that I can't solve. But I had so much solace. Sorry.
Thank you. How about that? But yeah, you guys mean a lot, and
Yeah.
it helped, it's such a frightening thing as new parents. So what the NICUs do and what you guys do is so cool, from Temecula to Chula Vista. I mean, the parents
Yeah,
that you
it's
impact
incredible.
and what you guys do is just, there's no words for it. So
No.
yeah.
Which clearly I exhibited there just a couple seconds ago. But thank you guys very much, and thank you guys for continuing to lead, be at the cutting edge.
Yeah,
of
and the
the
long days you have in
industry.
the labs and all of that, it's just, that matters. So
Yes.
yeah, that's it.
Even though you don't think that your placenta mattered in your case, from my standpoint, being a neonatologist for a very long time, that it was that thought, like, what if we had a placenta? Because we did go back and look at Colin and Patrick's and your placenta, which is mom and dad's, and they were normal. And so again, like I say, having that reassurance, is that another biomarker that we could add to our armamentarium to support families and provide some reassurance. The experience that you presented is actually when someone asks what's the most frustrating type of problem that you encounter in the NICU, we take care of a lot of very critically ill and sick patients, but sometimes it's the ones that are well, which they are now, but that uncertainty is really hard, and it's hard for families. And again, even though we're very advanced in neonatology, there's so much more that we need to learn, and I think that we're making headway on this, and it is through having that feedback from our families.
So there is a question about, like a person having, I think it all goes back to prediction and prevention as well. There is this question about like this person having like some very serious issues during the first, 2 pregnancies. And so she's asking, like what kind of advice, you guys can give her for future pregnancies. Again, probably this one like goes back to prediction and prevention, but.
Well, I can start by saying that this is where the placenta and evaluation of the placenta after delivery can play a role. Unfortunately, we're still sort of limited in terms of the information that we can provide in an ongoing pregnancy. That's one of the focuses for our center is, collecting maternal blood samples or maternal urine, other biofluids during an ongoing pregnancy, probing that in order to be able to sort of probe placental function. That's something we don't have yet and we're working towards, but we do have the ability to look at the placenta after delivery, and that information, as Karen discussed, there are main patterns of placental injury that are either vascular or inflammatory. Identifying those in correlation with the pregnancy and neonatal outcomes can really give a lot of insight in terms of recurrence rates. So I don't know if you want to address that as well.
Yeah, that's a great question. I know that that's a challenge that we've tackled. There are studies looking at whether we could actually image the placenta. I think that's something that that the center is working on now. Like, can you image the placenta in an MRI, similar to how advances we've made in fetal MRI during pregnancy? And I think those technologies and those developments are coming. There's also developments where, can we look at biomarkers that are circulating in mom that have been actually produced or released by the placenta that may tell us about whether a pregnancy is experiencing placental dysfunction in terms of inflammatory or vascular problems. But again, I think those are on the horizon and they're coming, but we don't have them yet.
You have mentioned, some stem cell therapies, given our proximity here with the consortium as well. If you could like maybe elaborate a little more on that one, thinking like in probably we're not talking about next year or in the next few years, but like see how you imagine what's your vision for in terms of the stem cell therapies applied to this field.
Yeah, so I do think they're on the horizon. There have been studies looking at brain injury where banked stem cells have been used to regenerate brain tissue. So those are kind of taken from adult studies, but the application to neonatal brain injury is that one is probably the most advanced that we have. There are other conditions like could stem and progenitor cells be used to regenerate intestinal tissue in babies that have suffered from necrotizing enterocolitis or intestinal dysfunction. There's actually stem cells being used in cardiac congenital heart defects such as hypoplastic left heart, where you can maybe there's some potential to regenerate cardiomyocytes. Again, almost every organ there is an application that stem cells could be relevant for the developing neonate as early as even the fetal stages.
I'll add to that not just stem cells, but sort of stem cell derived factors. So mesenchymal stem cells actually from the placenta have been found to have very sort of pro-repair functions in many different settings. And one hope is that maybe not the injection of cells themselves, but identifying factors that they secrete could provide treatments for things like chronic lung disease or even prevention of development of chronic lung diseases, for example, in a patient with bronchopulmonary dysplasia.
Thank you, Mana. Thank you, Karen. And like I want to give the chance also to the family here if they want to also to tell us a little more about like their experience, especially in the NICU. I mean, I know it's a very particular time of your life, but there are like also some it was a good outcome for you. So my experience, it was really like a lot of interaction with nurses and doctors. And I can only like speak highly about like that type of experience that it was very important to me. But I'm sure that also you guys have like something that you maybe want to add.
So in my experience, the scariest thing is in a NICU or in that sort of setting is the unknown, and it's you don't know what you don't know. Especially, Catherine and I are medical beings. We're educated and we can learn very quickly. But we don't know what the boys were going through. And that was very scary to us. But as you mentioned, Matteo, the volume of nurses that were talking to us, the amount of information that our doctors were providing to us, and the clarity that they provided to us, that's what really gave us solace, on top of the ability to address issues quickly, concisely, and with a plan that had been made years ago and was continuing and continuing and continuing. They were just executing on a plan that was already there. And for us, I saw that firsthand, and that's really what made me feel good about leaving that space. And I told many of the doctors there, and I very much meant it, regardless of the outcome, of the good or the bad, what happens with these boys, we knew, both Catherine and I, that the best people were working on it, and they were giving it 100%. And that was so touching to us. And I knew that leaving the place or going upstairs to try to sleep at night, that they're in the best of hands and that everybody down there is giving it 1,000,000%. And whatever actions they were or decisions that they had to make, we knew that it was in the best interest of the boys and that we were going to get the best outcome humanly possible with these little guys. So I think communication, I think that seeing that they had or knowing that there was a laid out plan and everybody there was so professional and calm. And although I put up the facade that I was so calm. Inside, it was just turmoil. It was what you saw up on the microphone or on the stage a little bit earlier. But yeah, I think that was my experience. I mean, really, the best of the best are working in the NICU. I feel. I think, yeah, couldn't be more thankful and happy that the boys ended up where they ended up.
Yeah, and just the level of care too, just having, I mean, we had our providers come up to, I mean, I wasn't there, I was upstairs. So just having them come up and have us be a part of that, like not being able to even be there was frightening. And so just having the care from the providers that would come up and have those conversations, and just all we can say is thank you. So in that opportunity, you know, the NICU, ooh, man,
Poor
there's something
Catherine
else. So
unable to see Patrick for the first 2 days, and that's very frightening. So yeah, she just couldn't see the poor guy, and the poor girl couldn't see the little guy for, you know, the first 2 days or 3 days, and that was very, very tough and challenging, I think, for her. The fact that it was 2 stories away was so helpful. Like, I just got on an elevator and would just go right down. That was so incredible. And then every time I was greeted with a happy smile on the face, and down to the young lady coloring name plate that said Patrick or Colin on it. Like, it was so touching, and it was great. And we felt like it's not home, but it's as good as it could be for these boys.
yeah, it was very important. There's places in the country that it's not even a NICU. So just the fact that we are where we are is just very fortunate. So again, thank you.
Yeah. Reading about twins, they say like, oh, we'll find out what level of NICU you have. And like, well, is there multiple levels? Or like, do we need that? And like, of course, we didn't have that issue whatsoever at UCSD.
Thank you so much. You touched on so many issues.
Yeah.
Probably too much.
I know.
So I just want to take like 20 seconds to say thank you to the organizers. Thank you to UCTV for broadcasting the event. And of course, like, thank you to the speakers and to the audience, both in person here and online. So thank you so much for coming.
Thank you.